This expert discussion focuses on new approaches to fat grafting. Of particular importance is the concept of adding volume and the role that fat grafting plays in facial rejuvenation for preventing atrophy and sculpting the face and neck. Dr. Little and Dr. Martin provide examples of their approaches and how, even though they differ technically, they both still achieve positive results. They also discuss the artistic aspects of facelifting and why this is as important as the technical details. Finally, they discuss fat grafting and how it compares to laser resurfacing.
I'm Fuad Nahai, and I have the privilege of conducting a discussion today on what I'm going to call recent advances in facial rejuvenation. And I have two good friends, two experts, both of whom have contributed significantly to the evolution of our thinking on facial rejuvenation. To my right is Bill Little from Washington, D.C. To my left, Tim Martin from San Francisco. And I've heard them talk. I've read their publications over the past several years. And I'm going to start by telling them my impression of how I feel their techniques have evolved. And I'm going to start with Tim, because I think with Tim I've seen much less change than I have with Bill. And Tim, would it be true if I say that over the years what I have seen change is the integration of autologous fat grafting into your standard high smash technique?
Yes, no, it is fair. I think beyond that, I think it was Jim Carraway said he thinks fat grafting is probably the biggest advance in facial rejuvenation in the last 100 years. I would say certainly it's the biggest advance since smash facelifting. And that's because it's given us a tool to treat something we hadn't really been able to treat before. Our laser procedures, our peels treat the skin surface, our lifts treat sagging tissue and redundancy, but we didn't have a way of treating atrophy. It was the missing link. We could put a cheek implant in. We had some fillers available, but the perfect facelift still had a bit of a cougar look to it because it was missing volume. Really through the perseverance of Sid Coleman and a few others, but I really credit Sid with showing me the way, we have this new tool that is arguably more important than many of the tools we've used in the past.
Bill, I've seen a dramatic change, especially the way that you now approach the periorbital area. It's completely different to what I observed in your own operating room 12 years ago, and also your approach to the neck. So can you just give us a brief discussion, a brief explanation, a chronology of the evolution of what you're doing now?
Well, I was trying to deal with volume back then 12 years ago, but I was doing it in a very difficult manner. I was sewing block grafts of fat and dermis, and the case you watched was
I helped you do it.
That was one of my first cases, but I continued doing that, sewing them in place. And the reason that I was doing that was that I tried the Coleman technique that others had tried, and I found it relatively straightforward and even useful in many parts of the face, but it confounded me in the lower lid. And I didn't develop a lot of bad results, but I had two. And they weren't very bad. They were pretty good, actually. But I learned how sensitive patients were to a subtle irregularity in the lower lid. And I was so put off by that that I dropped that, and I turned to alternative ways to do the volume, such as the dermal fat graft from the abdomen, later grafts behind the ear. It was all, quite labor intensive. They worked, and they worked well, but boy, they were a lot of work. So I was able to simplify all that when I got confidence in my lower lid fat grafting technique, and what helped that was reducing the size of the instrumentation. You asked me about the neck. The only thing about the neck I would say, is that I'd always focused a bit on the neck. And back in the early days, I'm a lot older than your interviewee to the left. Back in the early days, I remember when we didn't get very much improvement on our facial results because we weren't dealing with volume and other things. But we could all get an astoundingly impressive result on the neck if we had started off with a bad neck, because the two-dimensional profile of the neck before and after was such a dramatic thing for us. That all started with Millard, went through Guerra Santos, and of course many others. So I developed the technique when I presented results, because I only showed AP and lateral results, of putting my AP results up for about 2.5 seconds and quickly moving on to the lateral results, which I could leave projected as I discussed the case for a certain period of time. But that's very different from now. So the one thing I felt I could give my patients in my early days was a good profile look on the neck. I think that's very, very different today. I think the neck is still fundamentally important, but I must say that I have been wooed by the philosophy, and philosophy is a dangerous thing for surgeons. Surgeons must remain pragmatists first and foremost. Our historical texts and journals are littered with philosophy gone awry in surgery, but I must admit that I am wedded to the concept of a vertical vector throughout the platysma, and so I've been a bit swayed by that. That's been a European concept of late, and I must say I've been seduced by it. The trick now is to do less in the neck, do less centrally in the neck, and not compromise my principles so much that Tim and you will scorn me.
Bill, there's a very big difference in the way that Tim approaches the face and you do. Tim does the high smash with a lot of dissection deep to the smash, emphasizes the release of the parotid and zygomatic ligaments. You essentially undermine the skin and rely on your 5-ovicral sutures in the smash to improve on the jawline. I'm going to ask each of you how you explain the equally beautiful results that you each show with procedures that are totally different, not only in concept, but also in terms of technical performance. And perhaps I should ask you to comment, Tim, because he was doing a complex procedure and has gone to simpler. You continue to do the complex procedure and continue to have good results.
Well, I would say that Bill's procedures are complex. He's just a good surgeon who makes it look easy, like a good dancer makes a pirouette look easy. But he's still doing something complicated that not everyone can readily reproduce. I would also say that he's someone I've taken inspiration from, and I actually feel that we are very similar in our goals. In fact, I'm heavily influenced by his way of thinking. So I think we like the same things. I think we see things the same way. We've just developed technically different ways of getting there, much like I might prefer a spreader graft and Bill likes a spreader flap. They both prevent an inverted V and keep the airway open, but they're different things. He's trying to create much of the same improvements that I am, and he's moved around and found some different ways of obtaining the result he likes, and I think the results speak for themselves.
Specifically, can you address the question of the ligaments? Because I've always read and heard you emphasize the importance of releasing the ligaments.
Well, if you're using a smash technique, it's important because the layer is useless if it's bound down to the face. But Bill is even there are many surgeons who use a low smash technique and then they do a mid-face lift or graft the mid-face to make up for that shortcoming. Bill has developed a way of achieving that improvement. I guess now you're doing your mid-face less and using more fat in the mid-face, but he's getting an improvement in the lower face by bypassing those ligaments. He gets out in front of them and he's superficial to them. He's pulling the jowl up into the buccal recess, which I often have to fat graft, and you can see it in his results. There's a very athletic, youthful appearance to his patients when he moves that jowl up the way he does. I'm repositioning that with the smash, and sometimes that actually creates a different, harder, or more depressed look. I mean, each technique has its advantages and disadvantages, but it's definitely powerful what he's doing. I think we both want to get to the same place. He's found a way to bypass the ligaments that I have to release.
And of course, the SMAS has been the gold standard, and the superior SMAS, as Tim describes it, of course, is the current gold standard today, and he's remained a traditionalist in that sense, bound to his training and the advantages he had as a young trainee. I just see an alternative to it, but he and I both believe in the resuspensory aspects of facial rejuvenation surgery. There's a lot of information now from Val Lambros and others that downplay this a bit, with the suggestion that even gel formation, lower lid architecture, a number of things are very little involved with descent. Well, I don't believe that, and certainly in terms of the surgical pragmatism of resuspending descended tissues, it works, and it works beautifully in Tim's hands. Audiences are in awe of him, and it works in my hands. And we just use a different approach. I approach things superficially in the subcutaneous plane just below the skin, out in front of the ligament, yes, and over a glide plane that we didn't even know existed until 3 or 4 years ago because of our great Australian anatomist Ryan Mendelsohn. But it explains why all this works. And I'm using an old principle in the specialty based on the transfer of tissues, which is if you work very close to your target area, you don't have to do as much work to move it as compared with trying to relocate it at some considerable distance. And I'm taking advantage of that simple concept with one extra caveat. It allows me a purely vertical direction and a purely vertical vector. Now, Tim prefers and defends very well his more oblique vector, but I've always been in this within the face a believer in the vertical vector, and I'm able to use it in the simplified, superficial, sort of lightweight version of suspension, and it works simply because I'm working so close to my target area. Number one, and number two, my target area is not bound down by ligaments. I only get in trouble when I try to go posteriorly and lift, and then I need help. I use crutches such as a suture that bypasses the fixed mass, so that's Daniel Lavey's contribution, and others. So, but I think we're very much alike in this because we're going to see more and more people with fat grafting now widely appreciated now, and many courses taught how to do it properly. We're going to see a lot of people who I think try to sidestep the suspensory issues, and I think they're going to pay a price in the long term, but Tim and I will not, because we both believe in that fundamentally. I don't want to put words in your mouth, but we both believe in the suspensory aspect, and that volume is not a substitute for resuspending fallen soft tissue.
If I may, as I see it, Bill's technique, I think requires the experience and artistic skill that he has. My background as an engineer, it's easier for me to sort of take a tissue plane apart, shift it up a little bit, tack it down. I think watching what Bill does, he's imbricating tissue and he sees what he gets and he imbricates a little more. To me, it looks like there's more of a learning curve. There's more artistic input. I think his judgment really helps him. I think in some ways it could be more difficult for a beginning surgeon who doesn't have that background to do that. I'm not saying that raising a SMAS flap is easy for a beginning surgeon, but it suits my personality of just sort of delaminating the face and moving it up and sewing it back down. So there may be those sort of personal differences. As far as the vector goes, it's not really germane because we're doing you're down lower in the face below the zygomaticus major. So your procedure doesn't corrupt that function. You can go pure vertical. If I go pure vertical higher in the face, I pull the zygomaticus major off its axis, and the look isn't good when the patients talk. So I have to shift my tissue along the axis of the zygomaticus major to preserve a natural looking animation. It's not really different. We're just working in different areas, and we have to adjust our procedure to the local anatomy.
Let me just respond to you one point, Tim. You're so perceptive to realize that business about the level of it being below. It's really below the insertion of the into the modial area for the most part. And I think you're right. But one other thing, the reason there isn't a lot of artistic input necessary in recreating the facial curve that I want to create is the very fact that again, everything that I'm doing is wimpy compared to you from the surgeon's point of view. And my fixation is not rigid fixation or solid fixation; it's floating fixation. And no less a scholar of facelift than Cheryl Aston just asked me 2 weeks ago in Denver, how come the results in the oblique projection look better above the line of my plication, and the exact reason was that it's a floating plication. In other words, I simply remove the redundancy from the system. It's not an academic, it's not an artistic exercise. That part of it is pretty much autopilot, and it just has a way, because it floats, because I'm sewing to soft tissue, the fat specifically, there is reshaping in the fat superior to that line. It reforms and reshapes itself into the architecture of the lowest tension, which of course is a dome, which is what we want. So it isn't it's not an artistic effort on my part, and it's not one that need feel intimidation about. Some things, yes, the placement of fat, and that's another topic.
We're going to come to that in a minute. Bill, other than shaving several hours off the operating time, going from your more intensive and invasive procedure to what you're doing today, have you noticed less morbidity? Have you noticed quicker recovery? What else has changed?
Well, yes, but what's been particularly important, because Tim, I'm no longer doing mid-facelift. I would do it with the right patient, but I just don't find any need for it. And I think mid-facelift has seen its day, and I state very simply that mid-facelift can do 3 things. It can fill the lateral tear trough, it can improve the malar curve, and it can elevate the mouth. Fat can do 2 of those things better than mid-facelift, far easier with far quicker recovery. The only time that I would ever consider mid-facelift is for the patient with particularly low mouth position, who's especially unusual in that regard, because when you work with the mid-facelift, you do get an extra element in true, I'm not talking about shortening the lip, I'm talking about moving the whole aperture of the mouth vertically, and that's about my only remaining indication, and it would be an extreme case for me to return to mid-facelift. So that's so forward. Where does this translate for the patient? Because of course my recoveries are so much less. I now have recoveries very similar to what Tim talks about. The majority of my men go back to work at 2 weeks. The majority of my women go back to 3 weeks. This was a 5 and 6 week return to work before when I was working in 2 planes, one of them subperiosteal. So that's been the biggest difference. There's not been a lot of morbidity. I reported an 8% weakness in the lip elevators in my original paper on that. It reduced a lot, but it remained, and that's been essentially eliminated by giving up the mid-face component. But that the patients knew was transitory, which it always was. So the main difference has been the patient recovery.
Well, let's talk about fat grafting, which really is the major advance. I would say it's still in its infancy. I would say we still have a lot to learn about the science. I'll even dare, sitting between 2 experts, use the word unpredictable. I think we've all seen patients that have been disappointed because the fat didn't do enough. It didn't deliver on the promise that the surgeon had made to them. And we're also now beginning to deal with the problems of overgrafting of fat into the face. We have a series of overgrafting of fat in the eyelids. That was the first area. I've dealt with many of them, and compared to dealing with the overgrafted face, dealing with the overgrafted eyelid is relatively less difficult. So let's talk about where each of you feels we are with the fat grafting, and the question that always comes up, what's going to happen to that fat in 8 years and 10 years from now? So Bill?
All right, I again accord great credit to Sidney. Sidney wasn't the first. In the modern era, of course, it was Shakespeare in Argentina. But Sidney gets all the credit because he's the one that watered the seed and weeded the garden and grew it and reaped it and sold it and marketed it. So it's his baby, and it's an enormous contribution for a young man to have made. And it's transformational for the whole specialty. The wonderful things about fat grafting, as Tim said, it allows us to do something we simply couldn't do in a straightforward manner before. The negatives are the lack of consistency, perhaps, but it's not so much for it. I think it was in the beginning for me. I alluded on one case that I showed that was back in the period when I was regrafting lower lids 15% of the time. I don't regraft lower lids 15% of the time. To me, I'll not say that they're slam dunk, because there's that occasional patient, typically a secondary case, in which I won't get the fat. In fact, I'm facing one when I go home Sunday for tomorrow morning, for Monday morning. But that was a patient who had multiple things done to the lid, and except for those cases, and it's a very, very low incidence of unpredictability. I'm not sure it's much different from many of the other areas in which I labor in plastic surgery, but I know it's got that reputation. The one thing in the head and neck for me, the one area in the head and neck for me is neither the upper nor the lower lid, but it's the temple. The temple's a little bit more of a challenge in predictability, and that may be about the only one that I feel that about. I will say this, that I don't do fat very often as a separate standalone procedure in terms of people coming off the street and having it in the office. When I do fat grafting to the lips, for example, patients are undergoing a 2 or 3 week recovery. They're told no unnecessary talking for the first week. They're on a soft diet. There are a lot of restrictions on their activities that may help my perioral grafts do so well, but they do very well. But again, I've been doing it a long time, and it's been a long, slow learning curve. We have so much more information now that people can go through that curve now. Beginning practitioners can go through that curve in a matter of months or a year, what took me 10 years to get to, because we've got many people beyond Sydney now giving this advice. Tim, myself, many. So to me, it's not as dire a situation as many still suggest. For example, I have never removed fat that I've injected in the lower lid myself on any patient. I've done it 3 times in my upper lids, all minor, almost invisible, that I went back and did a minor removal. So there isn't this degree of, there isn't this enforced despair. You get upset when people still talk about all the problems associated with the transection of the orbicular during lower lid surgery, and then you say, well, I've had one in the last 6 years. Well, I feel a little bit the same way about fat. You become expert in eyelid surgery, without a doubt. I feel that I'm an expert in fat grafting, as Tim does also. So I want to hear how he feels about the negative side of fat. It is a learning curve, but there's so many more teachers now, and there's so much more sound data, and there's emerging science right and left, that I think we can avoid a lot of the complications of fat grafting. Can we avoid the judgmental problems about overgrafting? That's another issue.
Tim?
Well, I feel the procedure has reached a point where it's as predictable as anything else we do. Nobody leaves the operating room thinking a nose is not perfect. We work till it's perfect, but we still end up revising 15 to 25%. We accept that. We don't say rhinoplasty is a flawed procedure because we have to revise it. I would say people underestimate breast implant capsules, but there's a lot of them. I don't really do that surgery. Liposuction needs to be touched up. Eyelid surgery needs to be touched up. So, we're not going to get it right the first time. With fat, there is some uncertainty in everything we do, but I think it's come to the point where it's at a par with the uncertainty we accept with other procedures. It's just new. When people don't want to learn something, an easy way out is to be hypercritical. But even some of the most staunch critics are now backing down and trying it. I think they realize that it's reached that point. As far as disappointment, it's a very nuanced thing. We're used to looking at doing large things in plastic surgery, and we're used to looking at things in 2 dimensions. And looking at nuanced things on the face, looking at something in 3 dimensions, frankly, Bill has helped me with this. He's helped us all. But it's a constant learning process. I'm an engineer by training. I really want someone in our specialty who's truly an artist to step up and take hold of this tool and do something with it, because I think I'm just learning what the 3D anatomy of the face. It's a complicated thing to learn. And patients, of course, have even a lesser appreciation. So they just want to be transformed. They want to be beautiful. They want to look young, and they don't always see this. So it was typical in my early fat grafting. The patient would come back and I'd say, gee, maybe nothing happened here. And then I would photograph them and sit down with the photos. And if you look at them, you'll start to see that you did a lot. And it just doesn't jump out like putting a 400cc implant in does. It's not that obvious. I think at first patients and surgeons don't even appreciate what they're doing. It takes a while to understand a nuanced piece of music or literature or art. Then I think we basically, most of us are trained just in a technical, here's how you process and harvest the fat, and you strain it, and you inject 3 cc's in this area. You can have a technical success. You can get some fat on the face, and it can be an artistic failure. And that's the biggest problem I see with this, is that most of us aren't really creative enough to really harness the incredible power of it. We're filling the wrong areas. And you have to make some mistakes, to see what you did wrong. You have to get your patients back and work with them to, correct those problems to do better the next time. So, and you have to explain that whole process to the patients. Fat grafting certainly should be presented to patients as something that might be a series of treatments. They have to be aware that there's some uncertainty at this time. Obviously, I think this will change as we break down the biology of fat and so on. We're going to have some magic dust we sprinkle on our fat that's going to give us 100% take and more predictability. But for now, we just have to do the best we can. So patient disappointment doesn't mean that the procedure's flawed. Even surgeon disappointment doesn't mean it's flawed. As far as overgrafted patients, we have over-resected dorsums and rhinoplasty, but basically everything we do can be done poorly, and that's not a valid criticism. And especially the surgeons who are pushing the limits. See, I'm a follower. People blaze trails, and then I wait and I make sure it looks like they're doing something right, and then I slowly adapt. I can't. I don't want it. I want a small problem that I can manage, not a big one. But then there are other people in our specialty who truly blaze trails, and when you're out there with your face in the wind, you basically have to push that envelope, and you're going to cross a line now and then. And it's not a failure. It doesn't mean the person's a bad surgeon. It's just it's the way the world works. And thank God we have Steve Jobs and Sid Coleman and people like that who take that up. So there will be overgrafted patients, just like we have over liposuction people and over resected nasal dorsums and on and on and on. And how that fat is going to act in the future, we don't know. We're certainly putting a lot of filler in people's faces that we don't know what's going to do. And so to me, fat grafting has reached a point where it's on par with the other things we do in all those categories.
Have you had to deal with an overgrafted face?
Yeah, not personally.
How do you deal with it?
I have a few that I've actually. I have a few patients who will say, that they wanted a 3rd session of fat. I thought they were perfect, but they want it, so I put it in and they regret it, and then they have to wait for a while before I'll take it out. I mean, they'll hold on to their old picture and say, well, I was perfect here. I just should have stayed there. And I'm like, yeah, you should have stayed there, but you told me you wanted more. But I do see a number of patients who have been overfilled by other surgeons, and the good news is it usually can be dealt with. The fat can be removed. It's harder in some areas than others, but it's not an irreversible situation, and it's easier than managing some of our other complications. Some of the nasal complications you see are almost unmanageable except by an expert surgeon. But I would say most of the average fat grafting complications are something that an average surgeon could manage on his or her own.
Well, I'm going to differ with him, because I suspect Tim has talked about maybe his few patients where he have asked for more than maybe he wanted. But I think fat grafting rises to the level in certain situations situations where certain areas are essentially uncorrectable. And I've got a lot of experience with it. It may be my geographic location. I've had to deal with a number of really disheartened patients, and so it's best avoided. I don't think, Tim, that it's so easy.
It is the best avoided.
I think sometimes fat is ultimately uncorrectable. I could cite some examples of people that you probably know right now, but I'm not going to do that. I just think that this is the case. Maybe we can get out. Well, there's a leaden quality to the overgrafted face in which a true spark of animation can never be returned, and it has to do with smile. It has to do with the zygomatic smile as well as the oral smile. It has to do with just other aspects that go way beyond the lip that gets a little bit of a simian quality. There's a limit, even with injectable approaches to fat dissolving. But I just say that the more that we can do to limit that, almost inevitable development, and ask people to, again, use fat is a very powerful tool, should be used with restraint, but it needs to be used with principles. The other thing that I want to point out is that in the past, the people that we had to teach us about fat were largely right-brain thinkers. That's why they made these developments, and that's why they made these breakthroughs. That's why we now have engineering minds and plotting semi-scientific minds like my own that can at least regiment this a little bit more, categorize it, put it in different, and not that it should be formulaic. It shouldn't be, but most plastic surgeons feel comfort with formulas, and to a certain degree, Tim, you've given them formulas, and I've given them formulas that make it far simpler than the people who were more creative, more artistic, more right-brain thinking. So that's an advantage right now where we are as more and more people enter in that phase. So I think that the teaching is going to be more oriented to the plastic surgical pupil. And there was something else that you said, but I just that's the one thing I'm going to.
About the overgrafted face?
Overgrafted face, it's just tough. And I have you do what you can with liposuction, and then and by the way, I've been in a number of these cases with Sidney Coleman, by the way, as he's tried to reduce some of them. You do what you can, and then you turn to other measures. I've had to turn to rhidectomy, literally old-fashioned rhidectomy, because the liposuction couldn't go any further. And you've gotten as far as you can, then you need to turn back the skin, and then you begin the very difficult job of reducing the scarred subcutaneous layer with no idea what your underlying anatomy might be and all of that, and what your limits to resection can be. Using platysma where you can, other aspects of the smash where you can as a guide on. So and even then, not being able to get the job done. So it's best avoided.
I'm not disagreeing. I guess my point was that the typical complication, the irregularity, the oil cysts, are pretty easily managed, just like most eyelid or nasal complications are manageable. But then, of course, there's the nasal cripple, there's the eyelid cripple that in case is unmanageable. And the fat people you're talking about are the equivalent of some of these patients.
You've seen one end of the spectrum that's easy to deal with. He's seen the other end. My own experience is that it's fibrous and it's difficult to dissect out. Before we wind down, Bill, I recall that I won't use the word almost routinely, but I do remember you with the CO2 laser resurfacing the majority of your facelifts. I don't think you did as many. Just before we finish, I'd like each of you to comment on resurfacing. How much are you doing? And what is your favorite resurfacing tool?
Well, I don't resurface the face. Because I do wide skin undermining with very thin flaps for all the reasons that Tim talked about. And by the way, I use his approach in undermining. I think transillumination, I know it didn't arise with you, but you've kept it alive, and I think it's a safe way to do wide, thin undermining. I think it's the only safe way to do it. So I don't treat, but I do treat lips and I do treat lids. I do routine CO2 laser resurfacing in 95% of my upper and lower eyelids. I do periorbital resurfacing on almost everybody. I don't do on, of course, darkly pigmented African skins and some Asian skins, but most I do it. I can do it among other reasons because my lower lid technique does not have any undermined segments within it at the completion of the surgery. So all of the skin is intact, which is like in the spirit of pinch breath opacity, so that I can do it there with no concerns. I'm much more conservative about the lip. I don't like lip lines, but I really I don't like anything that we do in facial rejuvenation that's irreversible, and laser-based decoloration is largely that. So that I tend to compromise in the lips, and I tend to use a mix of, again, ablative laser resurfacing combined with increasing skill with sharp needle or blunt needle with subcision for individual riddance. I want to hear what Tim's got to say. I think Tim's done some. You're a little more likely to do some broader facial resurfacing, as I
No, not really. No. I think resurfacing has been really a disappointment to surgeons and patients, and despite all the technology and money spent, it really hasn't gotten anywhere, and doesn't really do that much. I rarely resurface, partly because it's not an artistic priority for me. I think the eye wants to see shape and contour. I know many women who have wrinkles who I find attractive, and I think what makes them attractive is that good neckline, that good jawline, that high cheekbone, that well-placed eyebrow. And a few wrinkles are not an issue, much like a fine piece of antique furniture. A scratch actually kind of authenticates it as the real thing, and if you dip it and lacquer it to the point that it's shiny, you've actually degraded its value. Whereas I've seen other women who have been resurfaced and lasered to the point where they've got perfect porcelain skin, but they have a jowly, saggy face, and those women have no appeal to me. So at least the way I look at things, it's a lower priority to me. Obviously, synergistically, you give a woman a well-contoured face, and then you give her smooth skin. That's the ultimate, to have both those things together. But on my list of priorities, I want that contour first, and the wrinkles are secondary. As a practical matter, I can't get all the resurfacing done the way I do my facelift, but I can resurface the mouth, I can resurface the eyes as much as Bill does. I think I can actually come close to what any laser can do with TCA, so I prefer that. I can offer it to patients at a lower cost, and if it doesn't meet our goals, then we can step up to laser, but 9 out of 10 times, I get them to the same place, and we're both happy. I feel dermabrasion is actually superior to laser. I think in 1997, I went on record at the height of the laser mania and said, I'm not getting as good a result with CO2 lasering as I was with dermabrasion, and everyone rolled their eyes, but I think it's proven to be true. Hyperpigmentation, that waxy, shiny texture that I don't like. Dermabrasion seems to be, at least for me, the least likely to create those problems. It seems to be our best wrinkle remover. A really strong phenol peel is a fabulous wrinkle remover, but still creates a little bit of a waxy texture I don't like. And then I found when I started fat grafting the mouth, it seemed like my dermabrasion got better. And again, it took me a while to figure out what that might be, but I think there's a little stem cell growth factor kick to the dermabrasion where when you put fat in the oral area and then dermabrate at the same time, it seems like it's gotten better. So generally, that's the area that I don't like to be wrinkled. It is unfeminine and unattractive for a woman to have a wrinkled mouth. We can control wrinkles in the forehead, upper face with Botox, and a few scratches elsewhere don't bother me. So it falls lower on my priorities, and often I turn this over to my associate or a dermatologist in my area to sort of finish the job.
Just to follow up on that, I forgot one caveat. very low density. I do all over with one pass at a density of 4. That's the old
I remember that
and I don't
study.
do it again for it because I'm not a laser expert. And to me, it's been sequela-free, meaning I haven't had one negative outcome. And I could probably push it, but I have no interest in it. The other thing I would say, and that I believe devoutly, is that I think the best thing for skin resurfacing is an old-fashioned skin reductomy. I think we accomplish far more, and I do use a wide undermining, and I think I accomplish far more, particularly with difficult things such as bitterness folds and things of this nature, than we can ever do with any resurfacing technique. So this is a case where, and I forget to emphasize that I think surgical redraping trumps most, not all, but most of what we can accomplish with resurfacing.
But we're going to wind down. I want to thank both of you. This has been fun, and it proves what we've always said. We all love this specialty. There may be 10 different ways to do the same thing. In the right patient, in the right hands, each and every one of them is the right way to do it. I'd love to sit here and moderate again for the two of you in about 5 years to see how much of what we're saying today has changed. I was very tempted to get you guys to look into the looking glass and tell us what are you going to be doing in 5 years and 10 years, but I'd rather come back and, same time 5 years from now and see what's been changed. It's been a pleasure, gentlemen.
Thank you.
Thank you. Pleasure.